Assalamualaikum.
Waalaikumsalam, Doktor.
Alhamdulillah.
How are you?
Alhamdulillah.
We hope of you, inshallah, all of you are healthy and happy and consistent in their study. I think you are going now to come to the clinic and the world soon.
Hopefully.
Hopefully, inshallah. Okay, I think it's already accepted just for final touch now. Let us start by Al-Kitab. Okay. Yes, who will be the first one to present?
Me, Dr. Zamil. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, everyone. My name is Zamil and I will be the first presenter today. And I will be presenting on the childhood seizure and neonatal seizure. So before I start, is my voice clear?
Yes.
Okay. All right, next slide. Okay, so first things first, what is seizure? So seizure is a transient sign or symptom resulting from the abnormal excessive neuronal activity in the brain. So, okay, so it's a transient sign or symptom due to the excessive activity in the brain. So next. Okay, then epilepsy. What is epilepsy? Epilepsy is a disorder of the brain characterized by a predisposition to generate seizures and its consequences. Sorry, give me a block. Okay. So that is epilepsy in terms of the theoretical part. However, in the clinical, how do we define epilepsy? It is defined as having at least 2 unprovoked seizures more than 24 hours apart, or 1 unprovoked seizure with the probability of further seizures similar to those having 2 unprovoked seizures before. Next. Okay. So it is important for us to know the difference between these terms. So epileptic seizures is those that I have mentioned before. And then we have the epileptic syndrome. So as you know, syndrome is a cluster of sign or symptom. So this epileptic syndrome, we can classify them based on the patient's age, clinical features, EEG, and also MRI findings. And then we also have the status epilepticus, in which it is the epilepsy in which patient do not have improvement in the consciousness within 20 to 30 minutes of cessation of the seizure. So it is a prolonged. Next slide. Okay, so these are some of the examples of epilepsy syndromes based on their age of onset and also their clinical features. So you can go through this later. So next. Okay, so how does seizure occur actually? So it is due to the imbalance between the excitatory and inhibitory transmitter, in which there is excessive excitation by increased production of glutamate. And not only there is excessive excitation, there is also a decrease in the level of inhibition due to low level of GABA, which leads to the seizure. So, okay, so for the classification, we can classify it into generalized and focal. For generalized, some of the examples are absent seizure, tonic-clonic, myoclonic, and atonic. So for focal, we have simple focal, complex, and also secondary generalized seizure. Okay, so this just shows how the ILAE classify the seizures. Next. Doktor tak ada ke? Okay, so what is the difference between generalized and focal? So generalized onset is when it originates at some point and it rapidly engage the entire brain. And focal seizures, it originate within the network limited to only one hemisphere. And there are also seizures of unknown onset in which we cannot determine whether it's focal or generalized. Next is the cause of seizure. So the cause of seizure can be divided based on the age. So in infants and children, most commonly we are thinking of febrile seizures, any infections such as meningitis, trauma, or developmental disorders. And in adolescent also, it's pretty much similar. However, we have to remember to look for any drug abuse which can lead to seizure. Okay, so one of the more common cause is febrile seizure. So what is febrile seizure? It is seizure occurring in association with fever, and it is in children between 3 months to 6 years of age, with no evidence of any intracranial pathology or any metabolic derangement. So few risk factors for recurrence in febrile seizure is those having family history, early age of onset, less than 18 months, low degree fever, and also a brief duration between the fever and the seizure. Next slide. Okay, the next cause that can also cause seizure is the meningitis. So in meningitis, some of the likely causative organism in patient less than 1 month, for example, GBS and E. coli, like in our previous class just now. So this can cause meningitis in this group of patient. And in older children, it can also be caused by strep pneumonia and also Neisseria meningitidis. Next slide. Okay, so how do we approach a patient coming in with seizure? So next slide. Usually, patient will come in with a complaint of maybe loss of consciousness or any involuntary muscle movement or confusion. Next. Okay, so in clocking a seizure patient, it is important to elicit this cause of their seizure, in which we have to ask regarding these 3 phases. So for the pre-ictal, which is before the seizure, we have to ask, is there any warning sign? What was the child doing? Any triggering factors, for example, sleep deprivation or flickering lights? And was the child well, or maybe the child have any fever, which we can suspect febrile seizures, and any aura. And then during the seizure itself, we have to know the duration of the seizure and also what happened during the seizure. Is there any tonic-clonic movement, tongue biting, drooling of saliva, and urinary incontinence? And post-ictally, we have to know how was the child and how long does the child take to return to the baseline? And is there any floppiness or weakness? Next, okay, so other history. We have to also ask about past medical history, patient having any previous head traumas or any comorbidities such as diabetes mellitus, because change in the sugar level can also predispose to seizure, and also any CNS infection before this. And also it's important to know about the drugs. Is patient taking any anti-epileptic, and maybe it is due to non-compliance that lead to the recurrent seizure. Ask about the nutritional history, poor feeding, any complications during birth, family history of seizure, epilepsy, and also social history of drug abuse and physical abuse. Okay, so after we have got the history, so we have to examine the patient. So generally, we look at the patient. How is the patient? Is he or she conscious? Any respiratory distress? Any dysmorphism? And any signs suggestive of injury or head trauma? And then also important to note the patient's vital signs. Okay, and then for the neurological examination, we have to check the TPR, which is the tone power reflex, and also Kernick and Brudzinski sign for meningitis, and the cranial nerves, and coordination and gait. And also we have to look at the patient as a whole, trying to find features suggestive of certain syndromes, because certain syndromes can cause increased risk of seizure. Okay, I will show the picture. Next slide. Okay, so for the first picture, on the left, it is a picture of a Point Weinstein, which is in the Sturge-Weber syndrome. This can also have increased risk of seizure, and also tuberous sclerosis, in which in tuberous sclerosis, we can see maybe patient have periangular fibroma, and also angiofibroma and Ashleaf spot, which is a hypopigmented macule at the back of the patient torso. So we can look for these signs. Next. Okay, for the investigation, for child coming in with their first seizure, we have to do the full blood count, serum electrolytes, and random blood sugar. If patient is unwell or not alert, basically we want to look for signs of infection through the FBC, and also any derangement in the metabolic, such as hypocalcemia, hypomagnesemia, because can cause seizure, and also random blood sugar to look for any hypoglycemia. And then if depending on our suspicion, we can do a lumbar puncture and also drug toxicology. And EEG is recommended after first afebrile seizure, and neuroimaging such as MRI if patient have a persisting focal deficit. Next, so this is for febrile seizure. Basically, it is the same. However, I would like to point out that EEG normally is not indicated in patient coming in with febrile seizure unless they have multiple recurrence or it is a complex form of febrile seizures. Then we will perform the EEG. And then we can also perform the chest X-ray to rule out the cause of fever. What is the cause of the infection in the patient? Next. Okay. And these are also pretty similar. And the EEG in child coming with epilepsy. Back one slide. Okay, me previous slide, please. Okay, thank you. So for EEG, also it is important because we have to classify the type of the epilepsy, because it is important in selecting the drugs, because some of the drugs can actually cause aggravation of certain types of seizure. Okay, so slide yang the next slide. Okay. So first aid measure during seizure. So how do we manage? So during the seizure onset, so first is do not panic, and we have to loosen the child's clothes and place the child in the left lateral position and wipe out any vomitus or secretion from the mouth. And very important, not to insert anything into the mouth, and do not give any drugs or fluids orally. and stay near the children until the child has fully recovered from the seizure. Next. Okay, so for child with epilepsy, for treatment in terms of the anti-epileptic drug, it is recommended if patient have 2 or more seizures. And the idea is we have to go for monotherapy as far as possible, in which we give one type of drug and we increase the dose until its optimum dosage. And if the first drug does not work, we add on a second drug and we optimize the second drug and we withdraw the first drug because we want to achieve, we want to try for monotherapy. However, in children not responding to treatment with 2 drugs, complete re-evaluation is required and drug level monitoring is usually not required except for phenytoin. Next. Okay, so these are few examples of seizure with their respective first-line anti-epileptic drugs. Next. And these are also for those epilepsy syndromes and their first-line and second-line treatment. Okay, next. Okay, this is what I want to say just now. So the EEG is important because certain drugs can actually aggravate certain types of seizure. For example, carbamazepine can aggravate absence seizure, myoclonic, and generalized tonic-clonic. So it's generally avoided. So next. Okay, and these are also few other side effects of anti-epileptic drugs. You guys can go through this later. Next. Okay, so when do we refer a patient? So when the child has poor seizure control despite monotherapy with 2 different drugs, and then if the epilepsy is difficult to control in the first 2 years of life, or if through imaging we see that there is a structural lesion. And it is important to refer immediately if patient have infantile spasm or behavioral or developmental regression. Next slide. Okay, so for the advice towards the parents, so we have to educate the parents in terms of the disease, epilepsy, and then emphasize on the compliance. And do not stop the medication without the doctor's advice because it can cause recurrent in the seizure. Avoid sleep deprivation, and basically we have to advise not to let the children to be alone. Okay, and use the shower with the door unlocked, not letting the children do outdoor activities alone. And also we have to inform the teachers about the child's condition, so the teacher is aware if a seizure breaks out at the school. Okay, so that's all for the childhood seizure. So now moving on to the neonatal seizures, which is seizures occurring less than 28 days of life in units. Okay, next, so for neonatal seizure, it is the most common manifestation of neurological dysfunction. And neonates may also exhibit non-epileptic events that can mimic seizures. So next. Okay, so these are a few examples of the non-epileptic events. So they are not seizures, but they're just mimics. So first is jitteriness. It is a stimulus sensitive. However, it aborts with gentle inflection. And then we also have benign neonatal sleep myoclonus. This only occurs in sleep and it will abort with arousal. And then another mimic is startle disease, in which a child have excessive startle, stimulus sensitive jerks, and generalized muscle rigidity. Next slide. Okay, so causes of neonatal seizures. So the cause, some of them are about the same with the cause of the seizure in the childhood. So some of the cause can be hypoxic ischemic encephalopathy, HIE, and metabolic causes such as hypoglycemia, hypocalcemia, drug withdrawal, any intracranial infection, cerebrovascular such as ventricular hemorrhage, and also epilepsy syndromes. Next. Okay, so for the investigation also, it's pretty much the same. So we have to do full blood count and then electrolytes, look at the blood sugar, and then septic screening, blood culture, and lumbar puncture if we have a high suspicious of infection, and then EEG and also neuroimaging. Next slide. So for the management, thorough history, physical examination, and neurophysiological assessment with EEG is required. In acute setting, anti-epileptic drugs are given IV. Maintenance therapy are usually not required unless patient have high probability of seizure recurrence. And also, upon discharge, if patient have abnormal neurological examination or abnormal EEG, so we will give the maintenance therapy. Next slide. Okay, so briefly, so when patient coming in with seizure, first important is we have to support in terms of the airway, breathing, and circulation, acquire IV access, and do the dextrostic because we want to look if patient is hypoglycemic or not. And if hypoglycemic, we will give dextrose. If not, we will confirm the seizure with EEG and then start antibiotics if suspicious of meningitis. And if the seizure is ongoing, we can start giving IV phenobarb. And if it does not resolve, then we can give further treatment according to this algorithm. Okay. Next. Okay, so I think that is all for my part.
Okay, so if we asked you now just to give a simple summary about 2 sentences to your colleague, what you are going to tell them?
So when patient coming in with seizure, we have, like I mentioned, several differential that we have to think of. So basically, we are trying to do investigation to find the cause of the seizure, and then we treat them.
What else? What is epilepsy?
Epilepsy is a disorder of the brain and which makes patient have predisposition to recurrent seizures.
Yeah, I mean here we cannot diagnose epilepsy without recurrent seizure unless certain circumstances. So to diagnose, we need recurrent, 2 or more. Okay, that is a very important thing. Just to know that epilepsy is a clinical diagnosis. Okay, epilepsy is a clinical diagnosis. The EEG will help us to define which type. Of course, to have like video for the child, if you ask one of the family to make video for us like that, so it is very important to know that it is clinical. The other will help us. And remember that there is some cases with epilepsy, which is the EEG looks normal. That's why sometimes you need to do provocative test. We need to do more stimuli with withdrawal of sleeping, like light, according to our suspicious, to see if there is or not. And also, there may be small percentages also of normal people who can get abnormal EEG. So don't go so hurry to rely on the initial diagnosis on EEG, but you need it. Okay, and good that you specified that the best investigation for imaging is MRI, but it carry a lot of logistic issues like its availability, its need for sedation for children, its cost, like that. Okay, so it is very important. Zuzamil, please. Now we can orient that collection of the history are very important. And you must be a good in taking a history. And you must know what is the cycle of diagnosis. I mean, I got one child with first attack of convulsion. And he has a positive family history of febrile convulsion. So my top priority now, because the diagnosis will be in 10, what did you suspect the diagnosis now?
Sorry, doctor. Again?
I didn't need to repeat many times. The patient came to you now with the first febrile seizure, and there is positive family history in about febrile convulsion. So what is your top priority now? Other than controlling the fit?
Educate the parents about the febrile seizures.
Yes, but to rule out other causes. Because he is a normal child. He can get meningitis, he can get trauma, he can get hemorrhage. So your top priority is to put for yourself to rule out the others. So I must be good directly. How is the neck? Is there any stiffness? How is the Kernick's Brodzynski? They are normal? Alhamdulillah, now I am not afraid. Then how is the neurological examination generally? Is there the child looks normal or abnormal? It maybe have background, cerebral palsy have background. So I am ruling out. That is the way which I put. I need to come to the conclusion that it is a febrile seizure. But to conclude that, I need to rule out many cases. Okay, that's why you must put for these cases. Oh, it looks with congenital heart disease with pan-systolic murmur can be VSD or fallow or like that. So I must go through the clinical examination to rule out any cyanotic, any dysmorphism like that until I come to the conclusion. So the cycle of ability to come to a clinical diagnosis must be very clear for every one of us. Okay, it is not rely on subtle diagnosis. No, your software must erase a lot of diagnosis which needs to be rolled out. Okay, so this is my advice for you, please. If I make the cycle now and I came to rule out all, but still I feel that this patient has very like meningitis. So I must go ahead changing my way of thinking now, and I must do for lumbar puncture and the other like CT, like whatever. I must speak to the family that I need to do LB and try to convince them like that. So I make the first trip. If I finished, alhamdulillah, if not finished, I still. Or, oh, I found the dextrose are very low. So what, Shafika, what did you suspect now?
Yes, doctor.
If you found the dextrose are very low,
Hypoglycemia.
hypoglycemia. So I know now my treatment, but what about the cause? It is just incident, the child sleep a lot, doesn't get any food supplementation, or
Will it be infection, doctor?
sometimes it can cause, yes, but the most important to rule out, yeah, of course, we must rule it. The most important, is there any metabolic disease in the family or not? Which are very important, okay? what happens? Sometimes the internet here is not so good. I may need to close the video for some time, otherwise it will be interrupted. So the most important here, to rule out any metabolic disease. Okay, so I will ask about family history. Is there any neonatal deaths? Is there any current disease in the family? Okay, then I am going to check, is there any abnormality in the blood gas? I may consider to do ammonia. I may consider to do metabolic screen, tandem screen. So all this will make me, so always I must be so hurry because I know the top important diagnosis. So I make a cycle. It is not simple, it is complex, it is not simple, it is like meningitis, not simple, it may be like metabolic disease, inborn errors of metabolism. I make another trip, it may be child abuse, it makes another cycle, it may be brain tumor, it may be. So all differential diagnosis must be put it, and you must build your history about that. Okay, so you must be able to come and conclude. Another important point for the convulsion, which you must be oriented, is the importance of the skin, as your colleague show you a lot of slides. Remember that skin and the CNS, they are twin coming from the skin, from the ectoderm. So we have a lot of cases of neurocutaneous syndrome, which must be rolled out. The third one, Shakin Ash.
Yes, Doctor.
How to resuscitate the child with status epilepticus?
First, we have to secure the airway, breathing, and circulation. For airway, we have to make sure that it's pattern. Breathing, we have to give oxygen supplementation, and establish IV access, and take blood for investigation, like full blood count, random blood sugar. Okay.
Yeah.
After we stabilize the patient. Hello?
Yes, continue.
Okay. After we stabilize the patient, we can give IV pyridoxine.
IV what?
And
IV what?
pyridoxine.
Pyridoxine.
Pyridoxine. A pyridoxine. Okay.
Right. On the start, before any anti-epileptic? Did you agree, Zuzamil, to start by B6?
Or IV phenobarbital.
Okay, so you are going to consider anti-epileptic. You must revise. We have a very nice table in the pediatric protocol. Okay, but I mean here for resuscitation, yes, number one, as you said, APC. And remember that you mentioned, very good that you mentioned already the dextrose, because dextrose is a treatable simple cause. If we detect, the patient can be escape this status by just a bolus of dextrose. And don't forget another D, which is the disclosure. I mean, I must see all the body. Okay, is there any berberic rash? It means the patient can get like meningococcal or pneumococcal meningitis. It will become as a purpura. Is there any background neurocutaneous syndrome, which can also precipitate for that? Okay. Is there any signs of trauma in the body like that? All this will not come without disclosure. Okay. And the important thing is the disability. If there is any abnormal neurological posture, abnormal neurological sign, the patient has a high arches, the patient has like that cerebral palsy. So remember that EBC plus 3D, DDD. dextrose, disability, and disclosure. Okay, this is the first one. And of course, you are managing the child, and there is another collector, right, to collect the history to give you, because it will guide you. This patient has history of post-streptococcal glomerulonephritis. So Shahira, what did you suspect the patient has now?
Glomerulonephritis, perhaps infection, nephritic syndrome, doctor?
No, glomerulonephritis. Glomerulonephritis, post-infection glomerulonephritis, yes. So
Yeah.
you must suspect hypertensive encephalopathy.
Oh, yeah.
The patient
Yes,
has
doctor.
severe hypertension, okay? That is a very, very important, okay? So every history, if someone guide you that this patient has a background of type 1 diabetes mellitus. The good convulsion.
Diabetic ketoacidosis.
Can be any types of coma, okay? Coma, primary, it may be hypoglycemic coma. And you must know that we have about 4 types of diabetic coma. The most common in children is the hypo and the DKA. So it can be DKA, but take care of hypoglycemic coma. It may be the child given already the insulin and he refused to eat. Okay, very dangerous, okay? And it can kill the child in a short time. It can be DKA, but at DKA, I must suspect now it can be complicated DKA because of very high, I am afraid it can be affect the brain like herniation like that or increase intracerebral pressure. So you must guide it by the history. Even if you are stabilizing, one of your team must go directly to check the history like that. That's why I think to deal with any complicated case, we must be very, 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 very systematized. Our brain must be ready to process all that one. Please don't forget to go through the pediatric protocol, okay, about the status epilepticus, what's its definition, what is the line of treatment and the management, okay? Am I clear?
Yes, okay.
Yes.
So now it's your turn if you need to ask anything about epilepsy. So is it clear? Okay. So we can go for the second presentation, please.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Can you all hear me?
Yes.
Yes. Okay. Okay. So my name is Muhammad Tarmizi. So I will present on the acute flaccid paralysis. So next slide. Next one. Okay. So for the definition, acute flaccid paralysis is the rapid evolution of motor weakness. So it is the duration is less than 4 days, with a loss of tone in the paralyzed limb. And this condition excludes weakness due to trauma and also spastic paralysis. So this condition is a medical emergency, and it is very important for us to learn about this topic because this condition can result in death and also disability, as you can see in the pictures on the right side. So those deformities are typically seen in patients with poliomyelitis. And also patient can and also the result can be death because this condition can also affect the respiratory muscles. Thus, the patient can have respiratory failures and causing death. We look at the terminology to understand more about the acute flaccid paralysis. So acute means rapid onset, less than 4 days. Flaccid is the loss of tone. So that's why we exclude the spastic paralysis, and also paralysis is the limb weakness. Next slide. Okay, so this is the definition by the WHO. So acute flaccid paralysis is any child under the age of 15 years of age with acute onset of focal weakness or paralysis, including the GBS, or any person with paralytic illness at any age when polio is suspected. So it is characterized by the flaccid, which is reduced in tone without other obvious causes, example the trauma. Okay, next one. So in this seminar, I will include case. However, I will not present all of it currently. I will go through the case together with the seminar. So I will explain about some of the disease, and then I will include this case inside my presentation. So the chief complaint is Inshira, a 7 years, 4 months old Malay girl, presented with sudden onset of bilateral lower limb paralysis for 3 days of duration. So basically, this is a common presentation of patient presented with acute flaccid paralysis. So we go to the next slide first. Okay, so actually this is the case definition for the infectious disease in Malaysia. So I just include this because we can read it later, because some of the acute flaccid paralysis causes is infectious in nature. For example, what we want to rule out the most is the poliomyelitis, because when it causes an outbreak, so it will cause a lot of high morbidity and also mortality. Okay, next. So this there is also a surveillance program called the Afp Surveillance, which is a part of initiative to eradicate the poliovirus infection launched by the Global Polio Eradication Initiative. So this is a partnership with the leading national governments, led by the national governments with for example, WHO, UNICEF, which the aim is to achieve a total polio eradication worldwide. So polio is still endemic in certain countries such as Pakistan, Nigeria, and also Afghanistan. Next one. This table is showing the protocol for the AFP surveillance in Malaysia. So I think we can read it later, but what I want to tell you guys about this table is that when we detect poliomyelitis, polio, we need to report the case within 24 hours of the detection, because we want to notify the community medicine, and then they will manage if there is any outbreak. Okay, next. So we will moving on to the etiologies of the acute flaccid paralysis. This picture shows the overall of the causes of acute flaccid paralysis, but it is too much, so I will skip and then go to the next page. Okay, so I will explain on this one. So we have to know acute flaccid paralysis can involve different sites in the neurological system. So when it involves the spinal cord, it can be due to the acute transverse myelitis, or there can be also spinal cord compression, like the space occupying lesion like tumor, TB. And then when it involves the dorsal root ganglion, it is usually by the herpes, CMV, and also rabies. And if it is involving the anterior horn cells, it will, usually poliomyelitis will happen at this site. And also if it is occur at the myelin, it is usually by the Golem syndrome, which can be either AIDP, or if it involves the axon, can be Aman or Amsan. And if it involves the neuromuscular junction, it can be due to the myasthenia gravis, it can be due to the botulism, and also tetanus. And if it is involving the muscle, it can be due to the polymyositis or toxic myopathy. Okay, next. Okay, so acute flaccid paralysis in Malaysia. So the number one causing of this condition is the Guillain-Barré syndrome, followed by CNS infection, transverse myelitis, non-polio enterovirus, hypokalemic paralysis, and also viral myalgia or myositis. Next. Okay, so what is the diagnostic approach for this condition? So this one is taken from the PBS protocol. It is a bit small because the orientation is portrait. So if you can pitch them to zoom, it will be better. So how to approach the patient with acute flaccid paralysis is we need to see if the patient present with any CNS symptomatology. For example, patient have like headache, vomiting, seizures. So it can be indicate the CNS disorder. If there is no demonstrable CNS disorder, it might be due to the musculoskeletal disorder. And then next, we need to identify. We need to ask the patient if there is any spinator involvement, because when spinator involved, it is usually by the spinal cord pathology. However, if there is no spinator, it not necessarily not by the spinal cord. And then the sensory loss, we look at the distribution whether it is involving the peripheral nerve or the dermatomer, because the dermatomer is more to the spinal cord. And then also to look at the reflex, whether it is absent, reduced, or normal. Okay. Next. Okay, so for the history, if the patient present with paralysis, so we need to inquire more about the onset of the paralysis. Either it is sudden in onset or gradual in onset, because in onset can be due to trauma. And then the distribution can be symmetrical or asymmetrical. Progress of the paralysis can be ascending in the case of GBS, and also either it is descending. If there is fever at onset, because it might get infection, for example, polio or enterovirus myelitis, transverse myelitis, epidural abscess. And then is there any loss of or abnormal sensation? It can be due to compressive myelopathy, transverse myelitis. Is there any neck stiffness which might indicate polio infection, enteroviral myelitis, and also GBS can present with this. And if there is any bladder involvement which can indicate spinal cord involvement, like transverse myelitis, compressive myelitis, the autonomic nervous system symptoms such as presenting in GBS or rabies, ptosis, which can be presentation of myasthenia gravis or botulism, facial weakness, which GBS can also have this kind of presentation, or myasthenia gravis, botulism. Is there any fluctuating symptoms and fatigability which progress throughout the day or improving throughout the day, which might be indication for myasthenia gravis? Is there any history of preceding febrile illness, fever, diarrhea, or URTI, which might be indication for GBS? Because in GBS patient, it is not due to the infection. However, in GBS, it is post-infectious autoimmune disorder. So the autoimmune, which is preceded by the febrile illness causing the disease. Next. And then is there we need to inquire more if there is any history of trauma to the head or neck, and then any painful spine movement or spinal tenderness, because it might indicate trauma or any abscess. Is there any respiratory insufficiency? It might be complications of those poliomyelitis and also GBS. And then environmental exposures such as lead arsenic, snake bites, such as neurotoxin snakes can cause this acute flaccid paralysis. Dog bites, rabies, and also honey injection for infant botulism, which is those less than 1 year old. And then it is very important to inquire about the immunization history, because the poliomyelitis is due to those who are not vaccinated, or if there is any outbreak happening. And we know that there's anti-vaxxer, so we need to keep our eyes on this history. Okay, next. So for the physical examination, it is we have to assess the general condition first, and then for the neurological, we need to assess the tone. It is reduced in patient with transverse myelitis, GBS, poliomyelitis, power. Yes, patient present with flaccid paralysis, so the power will be reduced or it may be absent. And then the reflex, it can be absent in GBS, polio, spinal shock. It is preserved. It can be due to the myasthenia gravis or botulism. If it is exaggerated, it can be upper motor neuron lesion. So it is not included in our acute flaccid paralysis. So is there any clonus, fasciculation? Fasciculation is a sign of anterior horn damage, which is in polio, can have this kind of problem. And then sensory impairment, is there any a sensory level? Because in patient with transverse myelitis, the distribution is according to the level of the pathology. So if it is involving T10, so the sensory affected, we can have a definite sensory level according to the lesion. And then spinal tenderness, we need to see in trauma or abscess. And then autonomic features such as bowel and bladder dysfunctions, pincer tone, and also patient's vital signs. And then we need to observe the skin if there is any fang marks, which might indicate the snake or the dog bites. And then special tests to assess the fatigability of the myasthenia gravis, and also straight leg wrist test. This is to rule out any radiculopathy. Okay, next one. Okay. So for the investigation, the most important one is the MRI of spine. So for this MRI, we need to, when we suspect there is a spinal cord lesion, so it is helpful in the transverse myelitis, space occupying lesion, the tumor and so on, abscess, and also multiple sclerosis. So in multiple sclerosis, we can see there is a patchy lesion in the MRI of spine. And then we need to do the lumbar puncture and send for the CSF analysis if we suspect if there is any CNS infection or GBS. So in GBS, there will be cytoalbumin dissociation because the patient doesn't have any infection. However, there is an inflammatory condition occurring due to the autoimmune. So there will be a risk in the protein level. However, the cells level remains low. So it is called as cytoalbuminogen dissociation. Then we can do the histology studies. So this is important to determine the diagnosis and prognosis of lower motor neuron disease. So we can do the nerve conduction velocity to measure how fast an electrical impulse moves throughout the nerve. So this is to differentiate demyelinating and also axonal neuropathies. It is helpful for GBS. And then we can do electromyography to distinguish denervation from myopathy involvement. And then we can send for creatine kinase, which might indicate muscle fiber increase. So it helps for viral myositis. And also serum electrolytes, for example, hypopotasemia, hypokalemia, because it can cause paralysis. Okay, next. Okay, so this is for the acute flaccid paralysis. I will explain on 3 diseases, which is the acute transverse myelitis, polio, and also GBS. Okay, so for the acute transverse myelitis, it is an acute demyelinating disorder of the spinal cord with cord swelling and also loss of function. It is a rapid development of both motor and sensory deficits at any level of the spinal cord. So it usually involves those 3 years old and below, and also can involve the adolescents. It is defined as evidence of spinal cord inflammation by MRI documented enhancing lesion or CSF pleocytosis, which there is increase in the white cell counts. And also there is increased immuno IgG index. Okay. Next. And okay. So the causes can be varied, can be idiopathic, 40% of the time. So it is post-infectious complications, can be triggered by respiratory, GI, or systemic illness. It can also be due to infection such as virus, mycobacteria, bacteria, syphilis, dengue, mycoplasma pneumoniae, and also parasites like schistosomiasis. And others which can cause this acute transverse myelitis is multiple sclerosis and also SLE. Okay, so the clinical manifestation. So for the neurological, basically acute transverse myelitis, I don't include the most common sites, which is usually affecting the thorax. And the clinical presentation will be varied according to which tract it involved. It is involving the corticospinal tract. It will manifest as the muscle, as the limb weakness. If it involves the spinal thalamic tract, it will affect our temperature and pain sensation. If it involves the dorsal column, it will affect our stability and also spatial perception. Okay, so the neurological symptoms is bilateral. It depends on the which tract involved, and the progression of this illness, which is the most severe manifestation of the disease of the clinical deficit, is between 4 hours and 21 days after the symptom onset. And then it can be motor presentation, sensory, and also autonomy. For the motor, there will be rapidly progressing symmetrical paraparesis with initial flaccidity followed by spasticity. And then for the sensory, there can be pain and paresthesia, back pain, and also clearly defined sensory level. And for the autonomy, there will be bladder and bowel retention in the early phase, and there will be incontinence in the late phase. Okay, so next one. Okay, I will skip this one. Next. Okay, so for the investigation, we can do the MRI spine. So it will usually shows the swelling of the cord, and if you use the gadolinium contrast, they will be enhancing the cord lesions, suggesting inflammation. And we can also rule out any spinal cord decompression from this MRI. So as we can see in the picture, this picture involving the cervical region. However, we can see the swelling of the spinal cord. And then we can do MRI brain. It is to rule out any space occupying lesion. And then we can do the CSF analysis to look for the pleocytosis and then to see the CSF protein. And then we can send also for the antibodies. Okay, next. For the management, we usually give the high-dose steroids, which is the methylprednisolone. However, if the patient is having poor response after we administer the corticosteroid, so we can consider giving IVIG, plasma paralysis, rituximab, and also cyclophosphamide. Okay, next. Okay, so the second one is the Golem syndrome. So GBS is an autoimmune disorder, often considered a post-infectious polyneuropathy. So it involves mainly motor, but also can involve the sensory and also sometimes the autonomic nervous system. The pathology is basically there is a demyelinating neuropathy and axonal degeneration. It can affect all age. It is symmetrical and also ascending. So as you can see, it affects either the axon or the myelin, the picture. Next. Okay. So this is an illustration to show the pathophysiology of this condition. So when there is an infection of the for example, virus. So our bodies will detect this virus, so or the bacteria. So they will detect the lipopolysaccharides or the oligosaccharides of the pathogens, and then our bodies will produce an antibody. However, these pathogens have a molecular mimicry, which their antigens is similar to the nerve, to the ganglioside antigen. This instead of just attacking the pathogens, our antibodies will also attack our own gangliosides, which we call autoantibodies. This will cause the symptoms in the Guillain-Barré syndrome. So it can cause the segmental demyelination. That's one. So clinical manifestation of the Guillain-Barré syndrome, there will be history of non-specific infection, such as patient can have GIT or respiratory infection. He can present with URTI or diarrhea before the presentation. And then the initial symptoms is like numbness and paresthesia, and then followed by weakness. They can have advanced symptoms such as progressive ascending paralysis. It can be bilateral flaccid paralysis, so it is ascending infection, and can also have cranial nerve involvement, frequently the bilateral facial nerve involvement, and then can have the Landry paralysis, which is the involvement of the respiratory muscles. So this one is very important because it can lead to morbidity in GBS if not treated early. And then there can be reduced or absent muscle reflexes, can be peripheral symmetric paresthesia in hands and feet, can have neuropathic pain develop in 2/3 of the patient, can have cardiovascular autonomic dysfunction such as arrhythmia, voiding dysfunction, and also intestinal dysfunction. Patient can also have bulbar involvement, which is the respiratory insufficiency, dysphagia. Patient can have dysphagia and trouble in his oral intake, can have facial weakness, often impairing signs of respiratory failure, can also interfere with the eating and increase risk of aspiration because of the bulbar involvement. Okay, so what investigation we need to send? So we need to send for CSF analysis. Yeah, the protein can be 2 times elevated. However, the cell count is still low, so it is called albuminocytologic dissociation. And then we can send for MRI scan to roll out other differential diagnosis. Can send for nerve conduction study, which the velocity is slow and reduced, and also the electromyography in acute nerve denervation, and also send for anti-ganglioside antibodies, which is to identify the subtypes of the Guillain-Barré syndrome, because it can be the Miller-Fisher syndrome, can be the Aman, and also etc. And then others can send for serology for Campylobacter infection to find the cause, but yes, it doesn't really matter because it don't change the treatment. And then for the muscle also nerve biopsy, but rarely needed. Okay, next. Okay, so for the management, we need to admit this patient for observation because we need to anticipate for the respiratory involvement. And then rapidly progressive ascending paralysis is treated with IVIG. And then if it is not effective, then we can do the alternative, which is the plasmapheresis or the immunosuppressive drug. However, steroid is not effective. But if I'm not mistaken, in our third year, when we are posted in the HTA, steroid is still given because they are saying that the drug is cheap, so they consider still give the steroid to the patient. Others we need to take care of this patient is the nutritional support, especially in those patients which having the bulbar involvement, pain management, and prevention of DVT or ulcer because the patient might have prolonged bedridden. And then we need to monitor the PEFR regularly. So we need the patient to blow the PEFR. But we need to monitor them regularly throughout the days. Okay, so next one. Okay, so the last one is the poliomyelitis. So it is an acute infectious disease in which motor neurons of the spinal cord and the brain system are damaged by the poliovirus. So it will affect the anterior horn cells. So it is a neurotrophic enterovirus, which means that it will go to our neurological system. It has a focal oral mode of transmission. It can cause debilitating paralysis, including respiratory failure. Okay. So next one. So the clinical manifestation of this disease, there will be a history of unimmunized or recent outbreak. And then the initial symptoms includes fever, headache, vomiting, constipation, neck stiffness, and also limb pain. And they can have very muscle weakness, may include respiratory failures within 1 to 2 days. So it is very acute. So it starts proximal. It is in contrast with the GBS. So it is a descending progression. So it starts proximal, go to the distal. So and then it can have reduced tone, mostly asymmetry, can have reduced reflex, normal sensory, and also involve the bulbar. Okay, next. So the investigation needed in this case is virus isolation from stool. So we need to sense two specimens within 24 hours. So they will be high yield the organism within the first week. And then we can send for CSF analysis in which there will be high protein levels, gliocytosis with either neutrophils in early infection or lymphocytosis in the late infection. And for the CSF analysis, the glucose level is usually normal. Okay, next. Okay, so for the management is mainly supportive and aim at limiting progression of the disease and preventing ensuing the skeletal deformities. So we give pain relief, physical therapy, mechanical ventilation in respiratory failure, and this disease is the primary, we call prevention is better than cure. So we need to prevent it by giving the vaccination. So of course we need to educate our community regarding the polio virus, because if there's too many patients which neglect the vaccination, then we might have the polio virus outbreaks. Okay, next one. Sorry, next. Okay, next, management. Management.
Which slide, Meiji?
Ada case belakang, bukan ni. Next. Okay, so we move on back to our case. So I did include the chief complaint, but the chief complaint just now is Malaysia, 7 years, 4-month-old. So she had a history of bilateral lower weakness for 3 days in duration. So for the history of this patient, for the HOPI, so she had weakness of bilateral legs. It is sudden in onset, progressively worsening within 2 hours. She is unable to move her legs before performing Maghrib prayers, and it involved from the level of umbilicus down to the toes. However, I cannot get the progression where it starts first for this case. And then she also complained of numbness of bilateral legs. So there is a loss of sensation towards pain and touch specifically. And then there is inability to sense of voiding and defecation during the illness. And she developed generalized abdominal pain on day 3 of illness. And then he was sent to the hospital by her parents after having this generalized abdominal pain. Otherwise, there is no weakness of facial or upper limb, as Jia is able to move and use her hand functionally well. And there is no history of trauma, fall, no illness prior to the onset of weakness, such as URTI or diarrhea, no fever, no dizziness, blurring of vision, ptosis, dysphagia, or any backache. There is no shortness of breath, and the immunization is completed and up to age. So for the physical examination, she was before that, what do you guys think from the history just now? Is there any diagnosis comes to your mind?
Acute transverse myelitis.
Yeah, maybe. Okay, so we have that for our working diagnosis. Okay, and then go to PE. Next slide. Okay. So she was conscious and alert. Cranial nerve are grossly intact. There was no nystagmus, no unilateral ptosis, normal papillary reflex, and also no facial asymmetry noted. The upper limb is normal, so I don't include the findings. And for the bilateral lower limb, so the tone is hypotonia with power 0 out of 5. The reflex is 0. Babinski is equivocal, clonus absent, and the sensory is reduced for the pain and the up to T10, and the perception is not intact, and also the anal sphincter was lax. Okay, next. So investigation was done. Full blood count is normal. Renal function test normal. Stool for AFP, no trace of poliovirus. Lumbar puncture was not done in this patient. And then spinal X-ray, there is no fracture seen. On MRI, there is an abnormal signal intensity within the spinal cord associated with expansion of the spinal cord involving from T5 till T9, and also from T10 until L1. So in acute transverse myelitis, we know what I just tell you now, that the common site is the thorax, but it can involve other sites also. And then there is abnormal signal intensity. The abnormal signal intensity is iso-intense on T1, hyper-intense on T2, and not enhanced post-contrast. So the next one is the picture. However, it's not very clear. So this T1 next. I cannot get the clear one. Sorry. Next, we go to management. Next, management. Okay, so how they manage this patient? So this patient is allowed orally accelerated, was put on CBD due to the spinatic involvement, and daily neurological examination, given rectal enema for her bowel problems, and also high dose IV methylprednisolone was given. It is stated 12 cycles, however, it's not effective. And then he was sent to HKL for 6 cycles of plasmapheresis. However, only completed 3 cycles as she developed complications such as hypertension after second cycle and non-itchy macular papular rash on the trunk after the 3rd cycle. And then she was planned for the IVIG, so syrup paracetamol 380 mg was given, and IV hydrocortisone 100 mg prior to IVIG, and then IVIG 9 gram per day over 6 hours for another 4 days. And then watch out for allergic because the patient have it for the plasmapheresis. And then next. And then she was referred for physio and rehab. And then the mother was taught how to use the clean insertion of bladder catheter the next week is planned, because this patient have the bladder incontinence, and also continue the night sprint for the acute flaccid paralysis. I think that's all. Okay.
Yes, Muhammad, can you summarize by 2 sentences for us? What is the taking home message from your side?
So acute flaccid paralysis is a rapid condition, which is usually less than 4 days. So characterized by the rapid onset, flaccidity, and also weakness of the limbs. And most important thing we need to exclude is the poliovirus infection. And then we need to find the cause and the treat, because it can lead to high mortality and morbidity.
Okay, do you need to ask any question to your colleague? Okay, just let me speak with you simple point. Very good to know that if you come to acute flaccid paralysis, number one, it is notifiable disease. You must notify to the Ministry of Health within maximum 24 hours. Okay, because they will guide you what you must do, what types of sample for investigation or like that. Because most of us are unable to imagine that sometimes you are the best one to pick a critical situation, like polio, like infectious disease, like whatever, okay, even like COVID, like that. So this is a very important point. It is notifiable disease. The second thing, it needs very high suspicious. And I need you always, there is a good medical series known high index of suspicious. We'll give you some cases and let you think what can be. What is the nearest thing come to your mind? And if you go deep, you will find yourself in another track. Okay? Because our medical practice, yes, common is common, but don't forget the uncommon. Okay, so common is common, but don't forget the uncommon. Just a while, please. Yes, Dr. Azorin, yes. Which baby? Yes. Is there any problem now? I am coming to you. I'm coming to you. Okay, just a while. So high index of suspicious are very important. Okay, we must take care about that, and it must be, as I told you, it must be a notifiable one. Okay. The last point, which you must know how to differentiate between upper and motor neuron lesion. Okay, usually for upper motor neuron, we are commenting about muscle tone, power, reflexes, sometimes set sensation, but you must comment also about many signs like ataxia sign, like clonus, okay, which I call it ABC, ataxia, B, which is Babinski, C, which is clonus, and fasciculation. Very important how to pick fasciculation, especially in the muscle, or in the peripheral muscle, or on the tongue. Okay, so that is the most important message we need to carry with us. Just 5 minutes, I will see one patient and come back to you for the last presentation. Okay.
Okay.
Yes, Assalamu alaikum.
Alaikum salam.
We can go for the floppy infant now. Okay.
Okay. So, Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all, okay, especially to Dr. Mossad. So, I hope that all of you are still having the energy to go through this last lap of the PBS. So, bear with me. Okay. So, I'm going to share with you about floppy infant. My name is Tengku Hakimi Mukris, Tengku Azrim. Okay, so the outline of my presentation, I will start with the definition and then go to the causes, and then emphasize on the history. What are the signs that we would like to look in a floppy infant? What are the series of investigation that we have to do? And also, what are the principle of management that we have to provide for the child? Okay, so the definition, okay, I would like to stress about weakness and hypotonia. It is of two different terms with two different meanings. So weakness, it means that the child has a decreased ability to voluntarily and actively move the muscle. Whereas hypotonia, it is the decreased resistance to passive stretching of the muscle. Okay. And what does it mean? Okay, so therefore, a floppy infant, it means a child with a generalized hypotonia. It may have together with weakness or no weakness at all. Okay. So what are the causes of that can cause hypotonia in an infant? Okay, it can be divided into central and peripheral causes. Central, of course, involves the brain or the spinal cord, whereas the peripheral, we divide it into four categories: the anterior horn cell, the peripheral nerve, neuromuscular junction, and the muscle. So here is a illustration to show what are the pathological disease that can lead to hypotonia in an infant. Here, for example, in central nervous system, chromosomal disorders such as Prader-Willi, it can lead to hypotonia, okay, in an infant. And then we go to the spinal cord, whereas in the anterior horn cell, spinal muscular atrophy, which had already been explained by my colleagues just now, whereby there is a degeneration in the anterior horn cell of the spinal cord. So spinal muscular atrophy is the common one. And then go to the nerve, whereby there can be congenital hypomyelinating neuropathy. And then in the neuromuscular junction, we have the myasthenia gravis, the congenital and the transient myasthenia gravis, as well as infantile botulism. And the last one is the muscle. Whereas, for example, like we have the muscular dystrophy, myotonic dystrophy, and metabolic myelopathies, which include your inborn error of metabolism. Okay. So the central causes. Okay. The most common, among the common cause of hypotonia in an infant from a central cause point of view is actually hypoxic ischemic encephalopathy. Okay, whereby it can lead to cerebral palsy, right? Okay, so this is the among the common cause, and then we have, for example, in a child, it can be due to brain tumor or trauma, infection, ischemia, hemorrhage, intracranial hemorrhage, metabolic disease, degenerative disease, as well as chromosomal disorder. Okay, for example, like Down syndrome and Prader-Willi syndrome. In the spinal cord, it can be due to transverse myelitis, tumor, infection that can lead to abscess, trauma, or infarction, ischemia. Okay, so here is an example of the central cause, which is the chromosomal disorder known as the Prader-Willi syndrome. Okay, Prader-Willi syndrome is characterized the molecularly. Okay, there is deletion of the long arm of chromosome 15 at Q11 to Q13, whereby there is loss of paternal copy. So the culprit is there is deletion at the chromosome 15, and the clinical features of the child with Prader-Willi syndrome, it includes severe hypotonia, which can occur in newborn and neonatal life, and then feeding difficulties, unregulated appetite, which leads to hyperphagia, and that also will lead to can lead to weight gain of the child, okay, which can increase the risk for childhood obesity. And the next one is short stature because of growth hormone deficiency in this syndrome. Okay, and also the child can have sleep disturbance, hypogonadism, okay, strabismus, and small hands and feet, behavioral problems, and intellectual disability. Okay, so here's the characteristic faces, the feature of facial appearance of a child with Prader-Willi syndrome, whereby they have narrow temple distance, okay, and nasal bridge, almond-shaped eyes, and mild strabismus, as well as thin upper lip and downturned mouth, okay, and it looks overweight, okay. For example, in this cute child, okay. Okay, so let's go to the peripheral causes of hypotonia, infantile hypotonia, okay, whereby anterior hornsel, the spinal muscular atrophy, as well as poliomyelitis. And the peripheral nerve, we have the Golem syndrome, as we have already discussed just now. And also we have the hereditary motor sensory neuropathy, which, for example, we have the Charcot-Marie-Tooth disease, and then tick paralysis as well as Bell palsy. Okay, the neuromuscular junction, the common ones is the myasthenia gravis, and also followed by botulism. Muscle, as I already mentioned to you, also another example of disorder that occur at the muscular level is dermatomyositis and poliomyelitis. Okay, polymyositis. Okay, so spinal muscular atrophy, which is an autosomal recessive disorder. Okay, autosomal recessive disorder, so that means that it usually commonly occur in consanguineous marriage. Okay, so whereby the genetic abnormalities is that there is mutation of the SMN1 gene, or known as the survival motor neuron gene. Okay, and it is characterized by progressive weakness and wasting of the skeletal muscle. Okay, so the clinical features of spinal muscular atrophy is that the child, okay, the newborn will have hypotonia, generalized weakness, and also this is the important finding that we have to look in patient with spinal muscular atrophy, which is tongue fasciculation. Okay, and also absent deep tendon reflex. Okay, however, as we know that spinal muscular atrophy, it has many types. Okay, we have the type 0, 1, 2, 3, 4. Okay, and in the neonatal life, usually the type 1, SMA type 1, okay, or known as the Wernicke-Hoffmann disease. Okay, usually the patient, the child can also have poor feeding, okay, drooling of the saliva because of weakness of the muscle of swallowing, and also, okay, here we go to the types of the SMA. Okay, so we have the type 0, 1, 2, 3, and 4. Okay, so the type 0 is the most severe form of spinal muscular atrophy, whereby the child will usually survive only to a few weeks of life after birth, okay, because of respiratory distress. Okay, and type 1 is the severe infantile form, usually occur in about one quarter of the patient with SMA, and the onset of the type 1 is at birth to 3 months of age. Okay. However, for type 2 and the later types usually occur later in life, okay, whereby type 2 is a more slowly progressive form, and it occurs in about half of the patient, and it usually occur later, which is at 3 months to 15 months of age. However, for the type 3, okay, it's a chronic juvenile form, occur in the childhood period, okay, whereby it occur in about 1/4 of the patient and after 1 year of age. And we have the type 4 of spinal muscular atrophy, whereby it's adulthood onset and normal lifespan. Okay, so the common type of spinal muscular atrophy occurring in the newborn life is the type 1. Okay, so here is a picture showing the different types, and also actually they have names for it. Okay, we have the Wernicke-Hoffmann, the Debowitz syndrome, And the type 3 SMA, we have the Kugelberg-Wallander disease and the type 4. Okay, and all of these have different presentation. And also, I would like to stress about the motor milestones. Okay, whereby in patient with type 1, okay, SMA, usually the child is unable to sit without support. Okay, but in type 2, it can sit, but unable to stand or walk without support. And type 3, it can stand and walk, but may lose ability to walk. And type 4 is like normal people. Okay. So another congenital disorder in infant is known as the congenital myotonic dystrophy, or also known as dystrophia myotonica. Okay, it's an autosomal dominant disorder whereby the genetic abnormality is that there is presence of CTG, or we known as the DNA nucleotide trinucleotide expansion in the DMPK gene. Okay, this is the gene that have this expansion mutation, and usually in infant, it is of the DM dystrophia myotonica type 1. Okay, whereas in type 2, it usually rarely occur in infant life. It occur in later age. Okay, and the clinical presentation of child with congenital myotonic dystrophy is that hypotonia and weakness, feeding and respiratory difficulties, characteristic faces whereby they have inverted V shape of the upper lip, thin cheeks, and concave temporalis muscle. I will show you the picture later. And the head may be narrow, high arch palate because of the in fetal life, the temporal and the pterygoid muscles, they are unable to exert sufficient force in the development of the face and head. Okay, and also the child have thin ribs and talipes, known as a clubfoot, and this is the also a prominent feature, which is arthrogryposis multiplex congenita, whereby it's a severe form. It involves contracture of many joints of the child. Okay, so here is a characteristic faces whereby I show you that they have the head may be narrow, concave temporalis muscle, V shape of the upper lip. Okay, and the child has respiratory difficulties and feeding difficulties. Okay. Okay, infantile myasthenia gravis is an autoimmune disease whereby there is presence of autoantibody directed towards the acetylcholine receptor on the postsynaptic membrane of the neuromuscular junction. And as a result, it will cause rapid fatigability of the skeletal muscle. So the clinical presentation of a child with myasthenia gravis is they have ptosis or drooping of the eyelid, okay, diplopia, double vision, ophthalmoplegia, bulbar and respiratory muscle weakness, okay, difficulty in swallowing, poor feeding, and poor head control. So, after going through many examples of the disease that cause hypotonia in infant, so what are the important questions that we have to ask, okay, from the mother, okay? Ask about the onset. Is it congenital or acquired? Usually, acquired, it occur about after a few days or a few weeks of life, okay? And also, is the cause of the disease is static or progressive? Static in the case of cerebral palsy, but progressive in the context of spinal muscular atrophy, whereby the weakness is progressive, usually involving the proximal muscle first and then going to the distal muscles. Okay. Any associated symptom, weak cry. Usually, weak cry indicate it is due to peripheral cause, but for a central cause involving the brain, usually the child will have a high-pitched cry. Okay, and poor feeding, any drooling of saliva because of the weakness of the muscle of swallowing. Okay, seizure, drowsiness, usually pinpoint to a central cause, and lack of response to visual and auditory stimulus. Okay, birth history is also important. Okay, as we would like to rule out any other disease that can cause hypotonia in infant. And among the questions that we like to ask is about the fetal movement. Is it adequate or any reduce in the fetal movement, which can suggest that the child might have a neuromuscular disorder? Okay, breech presentation. A child with a neuromuscular disorder can also be a risk factor for a breech presentation. Okay, and poly or oligohydramnios, usually a child with a neuromuscular disorder, it will lead to a polyhydramnios. Okay, because they impairment in the swallowing, right? Okay, and also any maternal exposure to toxin or infection, any birth trauma, complication of delivery, and also low cord pH and low APGAR score, which these 2 points will also suggest that the child might have hypoxic ischemic encephalopathy. Okay, so congenital infection and history of honey consumption. Why? Because if we introduce honey to an infant, it will increase the risk for the child to have infantile botulism. Okay, so family that I already emphasized just now is consanguineous marriage. Okay, it increase the risk for many autosomal recessive disorder, for example, like spinal muscular atrophy, and also other affected family members, okay, with the similar disease. Okay, so after we get the history, what are the signs that we like to find in the child with who has a hypotonia? Okay, from the general inspection, general examination, assess the mental status. Is the child conscious and alert, and quality of crying, high pitch or low pitch. Okay, posture. Usually in a hypotonic infant, they have a frog-like posture because of the weakness of the muscle and hypotonia of the muscle. Okay, so frog-like posture, I will show you the picture later. And dysmorphic features, for example, like about Prader-Willi syndrome just now, they have like narrow temple. Okay, also in features suggestive of Down syndrome, for example, like small ears, small mouth, okay, epicanthal fold, okay, and also neurological examination, head and neck, assess the cranial nerves and the limb, peripheral nerve examination, as well as the evaluation for hypotonia. We have a special test for evaluation of hypotonia. Okay, I will explain to you later. Okay, so in the first picture on the left side, okay, whereby this is a child with a Prader-Willi syndrome, and the sitting posture of the child is because of the hypotonia. Okay, and what about this? Okay, this is a child with, as you can see, there is a ptosis, bilateral ptosis of the eyes, and also external ophthalmoplegia, in highly suggests of myasthenia gravis. And also this is a picture of tongue fasciculation, okay, in a child with spinal muscular atrophy. Okay, so you have to look at the tongue also. Okay, neurological examination, the peripheral nerve examination. Okay, usually it will be upper motor neuron sign or lower motor neuron sign. Okay, and these are the the features of each of the two categories, each of the two signs. Okay, in upper motor neuron sign, usually the tone power, the tone and reflex will be increased, and also presence of clonus and Babinski. Okay, but in lower motor neuron sign, the tone and reflex will be reduced. Okay, hypotonia and also hyporeflexia, and presence of fasciculation, as well as no presence of Babinski and clonus. But also another thing that is not highlighted is ataxia, as being already mentioned by Dr. Mossad just now. Okay, so you have to assess about that too. Okay, evaluation for hypotonia, look at the posture. Okay, frog-like posture, and also horizontal suspension, whereby normally when we put the baby on our palm, okay, the baby will have a straight back with a head upright and limb flex. But hypotonia infant, it will give a inverted U shape like. Okay, and for a vertical suspension, usually when we hang the baby by our hands, okay, normally they will have flex knees and feet. But in a hypotonia infant, okay, which usually we will notice that is scissoring of the limbs and also slip to the shoulder. Okay, as though as the child will maybe have tendency to fall, okay, from our hands. Okay, and also traction response, look at the head lag. Usually it will have extreme head lag. Okay, so here's a picture of the vertical suspension. Okay, like we have the slip through shoulder, and also this is a picture of a horizontal suspension. The child, okay, have an inverted U-shape like, okay, and also this when we perform the traction response, so it will have a extreme head lag in a hypotonic infant. Okay. Okay. So hypotonia. Okay. To summarize, okay, in a hypotonic infant, okay, when we find that there is more upper motor neuron sign, so it will suggest a central cause. And also there are other features to suggest that the child might be floppy strong. Okay, but a low motor neuron sign, it will suggest a peripheral cause. Okay, and it will suggest this will lead to more features of a floppy weak child. Okay, so what are the features of floppy strong and floppy weak? So floppy strong, the same like in examination. So it will have increased reflex. Okay, there is extensor plantar response to Babinski. There is clonus, and the child also have global developmental delay, microcephaly or suboptimal head growth, obtundation convulsion, and axial weakness or truncal weakness as a significant feature. Okay, in a floppy weak child, they will have reduced reflex, selective motor delay, normal head circumference and growth, but with preserved social interaction and weakness of the anti-gravity limb muscle. Okay, so and also low pitch weak cry, tongue fasciculation, and paradoxical chest wall movement. So these are other additional points that we can look, okay, to ascertain that our diagnosis will narrow down to a central or a peripheral cause of the hypotonia. See, okay. So what are the set of investigation that we would like to do in to find out the cause of the hypotonia? Okay, so based on the examination, okay, if it is a central, if we suspect a central cause, look at the if there is any dysmorphic features. If there is, then we can perform karyotyping, okay, and will lead to the diagnosis. If there is no dysmorphic features, then we can perform the neuroimaging, which is a MRI of the brain. Okay, or if we suspect the peripheral cause, we can perform laboratory investigation like the creatine kinase, the CDM1, or for the congenital myotonic dystrophy, look at the repeat expansion of the nucleotide, spinal muscular survival motor neuron gene 1, check X-ray, and will lead to the diagnosis. Okay, or and it will lead to other set of tests. Okay, I will explain to you after this. So if the child has normal CK and also normal global developmental delay, so assess whether it is dysmorphic features, the baby has dysmorphic features or major anomalies or not. Okay, so it will lead to other specific investigation. For example, like in Down syndrome, the chromosomal analysis or the karyotyping. In CDG, or known as the congenital disorder of glycosylation, we can do the isoelectric focusing, VLCFA, or known as the very long chain fatty acid in peroxisomal disorder, and other investigation for other differential diagnosis that we suspect in this child, okay, that we can do. Okay. All right. So this is like the same. Okay. If the child have absent reflex and tongue fasciculation, then we suspect them spinal muscular atrophy. We do the SMN1 gene testing. Okay, and for like EMG, if we suspect the patient have myotonia. Okay, I forgot to mention that in congenital myotonic dystrophy, usually the prominent feature is myotonia. Okay, but in an infant, usually myotonia is not present. It's usually occur at present clinically at 5 years of age. Myotonia is actually a delayed slow relaxation of the muscle after a contraction of the muscle. So for example, like we ask the child to perform a fist, okay, a grip action of the fist, of the wrist. So when we ask him to open the hand, so that we will observe that there is slow relaxation of the hand muscles. Okay, so congenital myotonic dystrophy and other investigation that we can do. Okay. So, and lastly, the management, okay, of any hypotonia infant. And as for the first and the foremost, we have to treat the underlying disease. And also, we can also provide feeding intervention, because usually the child will have poor feeding and it will affect his or her growth. So we can either provide nasogastric tube feeding, okay, in order to ensure that the growth is achieved up to his age, okay, and also refer to physiotherapy and occupational therapy team, okay. As for physiotherapy, we would like to prevent the baby to have atrophy of the muscle, encourage muscle strengthening in the baby, okay, and also occupational therapy to improve the posture and the function of the child. And if in case of the child in later life have scoliosis and hip stabilization, also involve management by the orthopedic team, okay. And also another important feature is vaccination. As hypotonia infant, sometimes they have weakness of the respiratory muscle, and this like increase the risk for respiratory infection. So we advise and encourage vaccination in this child, okay. So that's all from me for infant with hypotonia. Okay.
Okay, thank you. Let us come for the last one, the previous slide. Yeah, usually we must start by the most important word, which is a multidisciplinary team. Okay, this is a very important. Any one of us going to be whatever is specialist, he is a unique one in any specialty. He cannot do it alone. So we need multidisciplinary team, which can include physio, occupational, dietitian, with the pediatric, with them CNS, genetics as included. And the second thing, many of the diseases may not have cure, but this is completely different from management. Even there is no curative treatment, we have a lot of things to do. And I need you to put it in your mind. Even many diseases, we don't have cure, but we still have a lot to do to make the life of the child and the family near normal, okay? As we speak about all that, about feeding, about physiotherapy, about occupational, all this. Number 3 is expectational. From the history, from the case, I must read and know how is the progress of the case. So I must put plan for a long time. I need to see this child every 3 months, every 6 months, because I can suspect that child can got this problem. So I am doing a good expectation. So remember this, please, for cases like that. In spite we don't have any cure, we have a lot to do. We must do it through multidisciplinary team. We must be expectational, okay, for any problem. Do you need to ask any question?
Is there any question from the floor?
Okay, I hope now, last advice. I need all of you to feel happy with the nervous system. Nervous system, most of you are very afraid. When you bring you one case of lower or upper or like that, most of you started to be panic. It is very simple. I asked, I think, some of your group to prepare the flow, yes, for the examination. You must know your flow for examination of nervous system, like motor, how to flow for upper or for lower motor neuron region. What about if I'm going to examine the cranial nerves? What is my flow to examine 12 cranial nerves? If I'm going to examine the ataxia, what is the area? If I'm going to examine the gait, how many types of gait? Listen to me, practice more and more. You are coming, inshallah, to the world. Practice even for normal child to check for the nervous system. You will find it very, very, very simple. Nervous system is 1 + 1 = 2. Is it upper or lower? If upper, I will go like that. If the patient is weak, is it upper or lower? So it is very straightforward, okay? Hoping the best of you, and if you need any help for anything, just contact me. Okay.
Inshallah, Doctor.
Inshallah. Thank you. See you again, inshallah, and hear good from you, and keep safe.
Okay,
Thank you,
very much,
Doctor.
Thank you,
Doctor.
Doctor.
Allah, Doctor.
Thank
Thank
you,
you,
Doctor.
Thank you, Doctor.
Thank you.
Make the SOB while you are coming back, inshallah, to the hospital. Okay.
Thank you, Doctor.
Inshallah.